Hello, I'm Ellie and I am a community stroke nurse specialist, and today I am going to discuss end-of-life care and stroke. To understand why this aspect of care is so important, we need to look at stroke mortality. Stroke, which is considered a preventable disease, is the second most common cause of death in the world. It's the fourth leading cause of death in the UK, meaning that around 7% of all deaths are caused by stroke. This also means that 1 in 8 strokes are likely to be fatal. There are some positives to note. The death rates since 1990 have decreased by more than half. Now that we know the mortality of stroke, let's look at when a person is likely to die as a result of their stroke. To the left of this graph is the percentage of when the person is likely to die from their stroke. The darker blue represents a person's first stroke, and as you can see, there is over a 60% chance that a person could die within the first 30 days of their stroke. That then reduces over time and becomes 0% after 3 to 5 years. The purple section represents a person's second or third or fourth stroke. Again, the first 30 days are at the highest, sitting around 20%, and again decreases over time. Interestingly though, it never reaches 0 around the 3 to 5 year mark. The other colours represent non-stroke related deaths. However, a person having had a stroke may have impacted on this. Thinking of this, consider how this applies to your area of work. What indicators are there of poor survival post-stroke? This depends on the location of the stroke within the brain and the size of it. For example, somebody that is diagnosed with a total anterior circulation, also known as a TACS, is more likely to die than someone who has had a lacuna type stroke. Other indicators include any underlying pathology, for example, anteriovenous malformation, the patient's age and other comorbidities such as diabetes, dementia or hypertension. Visible indicators could include severe limb weakness, unequal pupil sizes, a gaze palsy, which is the inability to move both eyes in the same direction, reduced consciousness, or incontinence. We are now going to look into end-of-life care. Please take a moment to read this definition of end-of-life care given by the General Medical Council. Think about, does this definition surprise you? Do you think of it differently? And how does it apply to your work? For a good source of information, please look into the Gold Standard Framework, which gives lots of information about end-of-life care. End-of-life care is the support for people who are approaching their death. It helps them to live as long as possible until they die, and to die with dignity. It also includes supporting friends and family and carers. The first essential aspect of end-of-life care is recognising the possibility of death and clearly communicating it to all, including the patient, family, carers and other healthcare professionals. The triggers listed here could aid that process. By recognising a dying patient, it gives them time to process the information and their family to process this information and news. It will mean avoiding unnecessary treatments and gives them time to plan. Other essential aspects include a family-centred approach with considerations into advanced care planning, clear communication and management of symptoms. The Dying Without Dignity report, done in 2015, was done as a result of investigations into complaints about end-of-life care, and there were main themes. The first being not recognising when patients were dying and responding to their needs. The second being poor symptom control. The third being poor communication. The fourth being inadequate out-of-hours services, which may or may not apply to your work area. The fifth being poor care planning. And the sixth being delays in referrals and diagnosis. What barriers exist? Denial or hope. This can be from patient, family, carers, or even the healthcare team. I've seen examples of patients that have been in an unconscious state and their next of kin is not willing to explore end of life. There can be a multitude of reasons for this. They are in shock. They've not had end-of-life care conversations, they don't understand the patient's condition, or they have unrealistic expectations of their care. Sometimes we need to establish the cause so we can help overcome this barrier. No definite diagnosis. Depending on the presentation and the CT scan, it sometimes can be difficult to establish a diagnosis. This does not happen regularly in stroke, but if it does, it makes it hard for the persons and their family to accept end-of-life care approach. It's very hard to understand why somebody is dying if we do not know what the cause is. Unrealistic or futile goals. As mentioned earlier, in stroke, our focus from the start can be on rehabilitation. We do not always have the discussions of end-of-life care, and if we don't have those conversations, it's hard for somebody to accept it, and it can create a barrier and resistance. Disagreement in the team about the patient's condition. Research has shown that nursing care staff are the most effective at recognising end-of-life care. This can often mean that healthcare professionals can be on different pages from each other. Doctors hold the duty to decide on end-of-life care, and if their views differ from the nursing team, then it creates this barrier. Failure to recognise key signs and symptoms. An example of this is when there are different care staff that come in on different shifts, meaning that small clinical indicators might get missed, and as new care staff come in, they don't know the person as well. It might take a previous member of staff or a family who's visiting that patient every day to recognise some decline. Poor communication. As most things in this profession, poor communication can impact on everything. I've seen examples of where a decision of end-of-life care has been made but has not been passed on to the wider MDT. A therapist turning up to do exercises can really upset the patient and the family and disillusion them and create that other barrier. Concerns about withdrawing treatment. This is one of the main things brought up by family in my experience. Being on end-of-life care does not mean that all treatments stop. We can still treat infections, for example. Just each decision needs to be planned and discussed with everybody involved. Fear of foreshortening life. As mentioned earlier, we focus so much on rehabilitation that sometimes the consideration of an end-of-life care can be seen as this. This now leads to end-of-life care in patients with stroke. This slide is about the symptoms that patients display the most. Respiratory concerns, mouth care were the common theme. Think about what you have experienced where you work. We then move on to the management of symptoms. Pain. Over 80% of pain can be controlled with straightforward medication. We need to consider the physical and emotional causes of the pain. Could it be a change of position is all that is needed to relieve it? Is it because they're in isolation? Are they fatigued, depressed, or feeling hopeless? And with stroke, it's always worth considering alternate routes of administration, looking at things like subcut injections or pain patches to deliver pain relief. Dyspnea, or shortness of breath or breathing difficulties as it's known as. Sometimes this can be caused by obstructions like secretions. This can be aided through simple things like using suction, and sometimes we can get a physio assessment to help with this. Sometimes we can give simple medication to manage it, or we can offer supplementary oxygen. Again, repositioning, changing the position. Simply sitting somebody up in bed can do a lot to help their breathing. Restlessness. Causes of restlessness can include medication toxicity, organ shutdown with associated metabolic changes, high calcium levels, increased pain, urine or fecal retention, dyspnea or hypoxia, sepsis, or psychological distress. Identifying the cause of the restlessness is key. Hydration. This is one of the most brought up concerns from family and carers in my experience. Please take a moment to read this slide. We never stop a person from drinking. With stroke, it's important to know if they're conscious enough to take fluids, if they have a safe swallow, and if not, how can we help them otherwise? Mouth care is key, and there is a separate teaching session on this. If mouth care is not given, it greatly affects the person's ability to swallow and enjoy the fluids being offered. Thank you for listening to my presentation. I've listed these as my key points: early recognition, clear communication, decision making, individualised care, and please act as a representative for your patient and raise any concerns you might have to a responsible healthcare professional. If you have any questions, please discuss with your trainer or send an email to the address on the screen.